ከዛ በፊት
Dr. Louis Zirkle, founder and CEO of Sign Practice International, and we'll have 5 presentations back to back. So try to stay awake. We get coffee candy outside or gum or water so you get your tea break.
For example, for
So
paper 1 and for paper 2, you can't give
we can play
one or two
Dr.
sentences.
Lewis's video.
Based on this, it is rating
In
scale. You can rate it.
versus 5,
Yeah,
versus 50.
then out of 50, you will score it. You can rate this one, no problem. So
This is
paper 2,
an
you will
excellent
score
organization. We
objectively
have
within
worked
like this. But
with
give the
Ethiopian
paper which is
surgeons
labeled
for
with
many years, and
label
I
the
have the
paper
highest
and the name of
regard
presenter. Okay?
for
Just
your
read this one.
ability
to say
and
right
for
statistics.
your thinking about
So
cases.
you give feedback. I
I
give
appreciate
feedback.
your giving welcome to the sign teams of Jean, Terry, and Frank,
But I don't
for
want
they
to
are
give
both
feedback
to
to
learn
it.
from you
No,
and
this
to
one
represent
you
sign.
know, just will do for us. It is to send
Marcel
based on
Proust
paper. Yeah.
said the real voyage of discovery consists not in seeking new landscapes, but in always having new eyes. That means you look at the problems in different ways. And this is very important because as surgeons, we have many choices to make during surgery. Thank you for your passion and your commitment to creating a quality practice care throughout the world. Let's continue to learn together.
Moderate the sessions. Dr. Said and Dr. Tazara, please come to the stage. Thank you. So the first is going to be presented by Dr. Nathanael, who will be presenting via Zoom on accuracy of predicting implant head size by digital templating with and without radiographic marker in hip hemiarthroplasty, a retrospective.
So I'm here to present our focus. So our title is Finding Complicated Development Beyond the Ethiopian Population. Dr. Samuel is the coming from the Department of this paper. So I have anxiety disclosure that's about the gist of answers for qualification. So these are outlines of my presentation. So we have some background, subject matters, result discussion, conclusion, and final recommendation as conclusion details. So as a background, pelvic fracture is quite common, accounts for 8% of all fractures. Even one study done from a specialist hospital was a combined pelvic fracture accounts up to 16% of visits to the hospital. So those fractures that are very serious, they can lead to death unless they are one therapy. So into the pelvic fracture, it requires both clinical as well as therapeutic evaluation to treat the primary. So when we order pelvic cases for patients with suspect pelvic fracture, so we usually order anteposterior leg and ankle injections. So whenever it's available, this can actually the means of diagnostic modality, but it's not available everywhere, especially in our country where there's significant limitation for physical ability. So research does show that there's significant variation in the pelvic morphology across different races as well as ethnicity. So the use of appropriate X-ray does not align with optimal for our patient can lead to diagnosis, delay treatment, and the little complication including additional radiation exposure as well as additional prices for liquid X-ray. So the objective of our study was to determine the ideal related pathopathologies in our population and then to identify factors that are possibly affecting the related as well as its numbers in our population. So our method was the study design was a conceptual study design. Around 140 male patients who has abdominal polycystic scar and for the education of others than known pathology like for problems in the abdomen. We call it this much number. Those guys who are older than 18 years old. And then each sample was in child classified with dysmorphic as well as normal based on using the different criteria. We have quite several criteria. So based on those criteria, we classify child sample into dysmorphic and then normal sample. And then with the CT diagram, we just extract the file and then we load it. And then we use radian diagram software for measurement. So the orthopedic variable is determined by the clinical as well as the orthopedic or occupation, and then the factors that are possibly affecting age, sex, and anatomy of the subject. So the technique used for the measurements of this angle was standard technique by IG, based on its extract from the previous study. So as you can see down the slide, so we discussed the radial line of yours, and then there's a portion for 3D MPR. So on 3D MPR, we can able to reconstruct these pictures, the mixed style construction, and research and para style construction. On the first picture there, there are three lines in the picture. As you can see, this is the reference line, a line that passes the CT sequence and through the centers of the sacrum. So we do have three lines: the gray line, the red line, as well as the green lines. So the green line is perpendicular to the gray line, where the left the system, and then the red line is a line that connects the square between the S1 and the inferior plate of the S2. So then before by this green line and the red line will be give us the ideal electrons, whereas the for outlet angles, we measure with one section of the paras which are over the superior rounders. So the line, so the green line is the perpendicular to the green line. The red line is the line that passes the superior portion of the superior rounders, and then through the middle portions of the S2. So then we followed by the red line and the green line will tell us the ideal outlet angles. So we also measure the AKT as well as outlet angles using as a technique on the APS species from on the surgeon on the chart. So there is left-right rotation, sagittal inclination. So when this is taken lens CG rendered image, the sagittal inclination when we incline in this position, we get image to be around 24 on the picture, and then the outlet angle we also determine this to be 46 centimeters. So we both the mixed sagittal construction as well as the 3D rendered image for measurement of the liquid outlet angles. So this is another version for analysis with simple logic equation by binary simplification. And then this is the result. So we got around 114 number of system, and then about with even distributions of 74 nodes and 74 nodes, and with every 45 pages. So this data shows about 54% was supporting sample, and then 46% are normal sample. So this table shows the result. So the average electron will be determined using the precise transcription as a chemistry. So as you see from the table, then the average of the will be determined as 40 degree, and then with any number of elect, it's almost similar to if there are some patient who have an ADX side, it is also an ADX side in that patient, is any almost similar to ADX side is a maximum of 55 degree. So when you see on this table, the degree we determine on the using the secret fluid as well as the sagittal construction, the average degree was almost the same. So this table also shows factors that affect the measurement is sex, male, female, and when you see this table, so males have relatively higher weight and females, 27 versus 20, so it also statistical significant. When you see that they 1800, it wasn't statistically significant. It was 39 versus 41. So it is statistically significant, but it's not clinically significant. So when you see the normal is a small sucker. For this small sucker, there is an increase in knee handle of about 6.6 dB, whereas there is no significant difference in the knee handle. So as age increases, the knee handle also increases. So the different degrees have been reported in the literature for the early development. So the first picture shows how we take a deep sweat and we can make a color for the cranial to determine the early development. So the data from our study show that the early development is 25 degree respectively, whereas the traditional, the classic teaching was for early development was 45 degree, but it was on intense. It was based on the expert opinion. There was no strong evidence until the paper in 1995 found that the alien was 25 degree and the Nottingham was 60 degree. Even another study which was using 3D construction so with alien was 25 degree, Nottingham was 45 degree. And then which shows every similar to the alien, so no similar to her, whereas the alien is 75, which support that there is significant ethnic based difference in the morphology of the sucker. So our study also revealed males have greater engagement than other females, which also supports this population-specific variation in the morphology of the sucker. So all these results highlights the complex relation between the sucker morphology as well as the human Muslim population. As a conclusion, the base in the treatment is different from the traditional practice 45-45. For some, assumed to be orthogonal, like 45-45, but it's not this the perfect treatments are no longer orthogonal X-rays as a treatment in 40 country. Safety rendering is also another fast, easy, accurate measurement when the system is available. SA sacral also there are sorts of variations in the definitions. As a recommendation, it's better to change the traditional practice, 45-45 to 25 to 40 degree, and then so we need to be very common to have a prospective prostate and trauma patients because I also studying in trauma patients, so we don't know what the trauma brought, what the trauma would cause any alteration in the electric artery. So we don't have a prospective prostate in trauma patients. That's needed for radio station to have for us. So we have documents and reference to Department of Orthopedics Department in the Medical Specialist Hospital to give me the chance to practice research and to achieve this paper. Then have also learned to express my sincere gratitude for your audience as well as for Science Project Care International for their invaluable support and contribution to our fellowship program, and then for our training as well. Thank you so much for meeting here and giving us. Thank you.
Good afternoon again. Welcome. For the coming 10 minutes, we will see or study on micros. So this is microorganism profile and resistant pattern post-operative orthopedic surgical infection. It's called, its nickname is called the micro study. And the whole aim is to call for a region and institution specific surgical post-operative guideline. So this is the study which was done while I was a fellow in Ganga Hospital. The only disclosure that I have, this study is financially supported by Alliance, Netflix. So, which is the motivation of the study? Why we are interested in this study? Objective, method, material, result. Finally, we will discuss and conclude on the point. Why we are interested to see this one? Why we are interested on post-operative surgical site infection? That will be one of the most important entities. So, we start couple of cases. One, post-operative surgical site infection, it is the leading cause of morbidity and mortality, and it's also one of the top cause for prolonged hospitalization, and it is associated with a catastrophic health expenditure due to expensive treatment cascade for such population. And the other important thing, it has a multi-directional impact on patient, community, family, as well as health institutions. And the most important will be the last dose, which means it will lead the microbiological resistance to the antimicrobial. So this microbial resistance for antibiotics that we have, it will lead for multi-drug resistance, and finally it will be one of the difficult things to manage. So when you see the incidence of surgical site infection, there is a study which was done by the global surgical team, and they reported it as 7.4 for high-income country, and it will be doubled for middle-income country, as you see 14.4 middle income, and finally the low-income country will have a triple burden, 20%, right? 20%. So it is associated with a lot of resource again, and you can imagine how much it will be difficult for the management. There's also another systematic review which was done on studies done only in Africa, and they reported as the prevalence or incidence of, so this incidence of surgical site infection reached from 2.5 up to 30%. So there is a wide range from region to region. The incriminating cause of infection in post-operative wounds or post-operative orthopedic wounds will be the virus. There are a lot of microorganisms which are incriminated as a cause. Most commonly, the two leading cause of infection from literature as well as textbooks are Pseudomonas aeruginosa and Staphylococcus. But there are a lot of bacteria mentioned again, a lot from gram-negative species as well as Candida considered as one of the cause for such type of infection. Another key point is the multi-drug resistant microorganism, and it is reported as 37.5% of the microorganisms which cause infection in post-operative wounds are multi-drug resistant. So from this, we can anticipate how it will be challenging to treat these patients. There is one study from Indian team. They include more than 400 patients, and the prevalence of MRSA, multi-drug resistant staphylococcus, was really high, 55%. 55%. So it's all up an alarming number to proceed. What was the rationale of the study and what was the significance of the study? The rationale was like most of the study which was done before, they have less representation for low and middle income country. They are done either in middle income country or high income country. The other thing, most of the studies they are from a single center, they are retrospective with small sample size. Small sample size. So it means there could be bias. So we need to keep that one. The other key point is the regional variability among low middle income countries not addressed well. That's why we wanted to conduct this study to fill this one. We will plan to address with this study about the geographic variability of the causative microorganism. And we believe that this study will have a significant impact on utilization of institutional, regional, as well as national protocol development for antibiotic infection. The reason is the causative microorganism from region to region will be different. Objective was to identify the most common microorganism which cause infection in post-operative surgical wound, and finally the antimicrobial resistant pattern was the main two objectives. The study was a multi-center, multinational study. It's a kind of cross-sectional study using the retrospective data. We include 24 countries from 5 big regions, including the Asia Pacific region, Southeast Africa, West Africa, Latin America, and the Middle East with UK. So these all, which are highlighted with red dots, are represented for this study. Inclusion exclusion parameter, those patients, adult patients more than 18 years old who have surgical site infection after operation, they are included, but they need to have closed injury. By default, open injuries are excluded. Patient with replacement, either hip or knee replacement, hemi or total replacement were included. Spine surgery, then for degenerative spine were included, and orthopedic oncology surgery, including amputation, were included in this study. Why? Open fracture, patient with previous surgery at the current operation site, patient who have infection at the site, delayed presentation more than 2 weeks, and the patient with non-knee, delayed pain, and malignant were excluded since they have different characteristics. Sample size was calculated by online sample size calculator, considering this all factor to power the study. So isolation of microorganism frequency, it was taken as 20% from one of the paper, and the margin of error was 0.5%, confidence interval 95%, and since we are using region, then country, and institution, we use a labeled type of sample. So we use a distinct type of file. And finally, the total sample size was 2,038 patients. All patients who have all patients who have surgical site infection after operation were included until samples. We get IRB approval from Gang Hospital, where I was doing my fellowship. We developed structured questionnaire for the data extraction, and the data extraction was entered into Kobo application, which is a free application like that of RedCap. And all the selected centers were given the granted for the Kobo to collect data. And the data quality was approved by the PI, and there was also personnel who were identified to control the quality of the data. These are the data that we collect from for each patient, patient demographic characteristics, bacterial profile, antibiotic sensitivity were collected. Once we finish the data, we extracted from a Kobo tool and enter into a species for further clinical analysis, and the descriptive summary measures were done. When you see the results on the social demographic characteristics, total number of patients, as I mentioned, 2,038 patients from 24 countries, from a 5 big region. 64% of the patients were from the age of 19 to 60 years old, and nearly two-thirds of the patients were male. When we see the region, from Asia Pacific region, we have 9 countries contributing 1,302 patients. Southeastern Africa, including 4 countries, including Ethiopia, they contributed 341 patients. Latin America, 195. Middle East and UK contribute 120, and West Africa from 3 countries. We were able to recruit 8 patients. Type of surgery, most of the surgery were traumas for 70%, spine surgery account 70%, and joint replacement were 30%. Implant used, we used implant for 93.5% of the case. Other patients didn't have implant thickness. Like, for example, if they are having amputation, it's not having implants. The type of implant, stainless steel account nearly 60%, followed by titanium. And when you see the type of infection, whether it's superficial or deep, 52% of the infection rate found to be deep surgical site infection based on CDC guidelines. Type of bacteria based on the region. The specific points that I want to mention is based on the 5 regions, the type of microorganism which cause infection were completely different. For example, there is a little predominance for gram-negative than that of gram-positive. It is not statistical significant. 1,024 were contributed from gram-negative, 1,014 were from, gram-negative was higher than that of gram-positive. And the 2 regions, the Asian Pacific as well as Latin America, the most common cause of infection here found to be the gram-negative. Specific bacteriology, gram-positive, from the gram-positive, Staph aureus was the leading cause of infection, 35.5%, followed by epidermidis. And unlike that of the previous study, which said MRSA prevalence was 55%, here it is, in our study, it is 2.6%. 2.6%. From gram-negative, Klebsiella is the leading cause, followed by Pseudomonas and E. coli. If you see the area specific, again, Asia Pacific and others actually, Staph aureus is the leading, followed by Klebsiella and Pseudomonas. In the West Africa, it is completely different, right? The leading cause is Klebsiella, 30%, followed by Pseudomonas and Staph aureus. So it means like we have different type of bacteriology which cause infection at different regions. Antibiotic sensitivity, 89% of the surgeons, they reported like they use cephalosporin as a prophylaxis, either it is first, second, or third generation. Similarly, cephalosporin resistance was also reported in 93% of the conditions. So there is fallacy. That is one of the interesting findings. When you see the antibiotics with a great sensitivity for gram-positive bacteria, it includes this one: only gentamicin, amikacin, linezolid, and piperacillin were having a good sensitivity rate for gram-positive. Unlike gram-positive, for the gram-negative, amikacin, neuropinion, gentamicin, and ciprofloxacin were found to have a good sensitivity rate than that of the others. As a discussion, we believe like this study, even though it is a kind of descriptive study, it highlights the variation in bacterial growth as well as antibiotic sensitivity based on the different region, which necessitates the need of reformulating the prophylaxis of antibiotics based on the region. So that's why we call up each institution and region to have their own protocol based on the antibiotics, the microbiology identified. There is a fallacy, as I mentioned, the resistant versus the use of prophylaxis. That's also another point to focus on. And there is also an explanation. We can outline explanation for why we have variation in microorganisms. There are 3 differences. One is different geographic distribution, thus there is different resistance pattern, and finally they will have different surgical procedure at different regions. So these 3Ds will be cause or explanation for regions might have different variations. As any research, this research has a lot of limitation, of course. One of the limitations is being retrospective in nature. We didn't believe being retrospective affects the results because we use the microbiology assessment, which is generated by the computer, but still it is a retrospective study. Some size different among different regions. If you see in one, for example, in Asia, it is 1,300, while others it is 120 or something. So there is variability. Heterogeneity also there, different procedures were included. That's also another thing. And lack of validation for bacteriology isolation is also that is. Yeah, so lack of validation of bacteriology diagnosis, we can't control, it is uncontrolled factor, but it should be mentioned as one of the limitations of the study. But of all, we believe that this study is one of the largest multi-center study on orthopedic post-operative infection to show the various type of microorganisms and antibiotic resistant pattern in low and middle income countries. In conclusion, the take-home message of this study will be each institution as well as region need to have their own institutional protocol based on for the prophylaxis and for treatment purpose based on their cultural sensitivity. This is the summary. Thank you very much.
So this is a paper done in Bardar University, in the orthopedic department when I was final year, on prevalence and associated factor of surgical side infection after intramedullary needle in surgical implantation generation method sign or of open femur fracture in the European special staff. My name is Ashraf. Okay. So these are my presentation outline, introduction, objective, methods, result, and miscalculation, recommendation. Last we finish with acknowledgement. As introduction, surgical site infection is according to CDC and NHS criteria, and surveillance is infection within 12 months of surgery in patients with implant, and within 30 days of surgery without implant in situ. So more than one of the post-operative days in the world are related to with this surgical site infection. Open fracture are high energy, usually they will high energy injury lead to increased risk of infection and wound complication. Intramedullary nail is one option for stabilization of this open femur fracture. And surgical site infection related to intramedullary nail is considered as serious and difficult to treat once it is happening. This complication which may cause delayed healing for the fracture and the limb function loss, or sometimes it may end up with amputation. So surgical site infection imposes significant burden to the patient in healthcare system in terms of prolonged hospital stay, spend time in intensive care unit, readmission to hospital, long-term disability, contribute to spread of antibiotic resistance, increased treatment intensity, substantial financial burden to healthcare system as well as the patient, the family, deterioration, quality of life, and unnecessary deaths. So so this study assesses the prevalence and associated factors of this surgical site infection. The result of this study will provide feedback on hospital manager, to surgeons, and employees as baseline for information about this surgical site infection. So when we see objectives, the general objective to assess the prevalence and associated factor for this surgical site infection after signing was done for open femur fracture. So specific determines the prevalence of this surgical site infection, and the second specific objective is to identify factors associated to this developed surgical site infection. When you see method and material, the study design is this institutional-based cross-sectional study. The source populations are all patients which are open femur fracture, were admitted from January 1 to 2020 to up to July up to 2023. So this study population, all patients admitted with the diameter of open femur fracture, operated with the cyanide in orthopedic surgery department at the hospital for 3.5 years. So eligibility criteria are including criteria. So So patients who are fully documented on the chart or electronic data from Sign Online Surgical Database, patients whose follow-up status is clearly known, which is documented in the database or the chart. Patients who are developed infection on the site of surgery after 1 year were excluded from this study. Sample size, so this is calculated, but our patient with this 3.5 years, the old patient operated with this signing with open femur fracture were 125. From this, 10 of them were out of this study due to the lack of complete documentation in the chart or database. When you see data collection procedure, the structure questionnaire was used to collect data were collected from science surgical database and including the chart. Data were collected by the data collector are written in one GP after the train. So study variables, these are variables. There are variable dependent variables. These are operation definition, operational definition. When you see data processing and analysis, data was coded internally using P4 version 7 and export for further analysis using SCPSS window version 23. Then descriptive statistics like frequency per used to describe by variable, table used for data presentation, both by variable and multi-variable. Initially by variable in the last year when those significant into multi-variable logistic regression model was used, and the 95 confidence interval was used like P less than 0.05 where thickness statically significant. So ratios to compare association between dependent and dependent variables. So this result, total 150 study participants were enrolled. So the mean age of the participants was this one, and more than 2/3 of them were male, and almost trauma, when you see the trauma, gunshot is the commonest, 71.3%. That time is a bit war time in the northern part of Ethiopia. That's why gunshot is the commonest here, unlike the commonest trauma. This is social demographic, the clinical objective. When you see the prevalence, so almost surgical site infection was around 12.2%. And the development of this surgical site on patients who took antibiotics before and after 6 hours of injury was 6.7 and 17.85% respectively. So patients who operated one and more than one debridement, again, there is difference. More than one debridement is reached to 25%, and those who have only one debridement, they are around 6.3%. They develop cervical site infection. So these are the factors which are initially significant in the by variable logistic regression. Then lastly, we get two variables which are clinically significant in the multivariable logistic regression. So these two are the prevalence, almost 2.5, and so when you see almost similar, this prevalence is a bit lower than that study than in Addis Ababa, reported almost in Black Rhinos, almost 30.6%. So almost similar with overall prevalence surgical site infection in post-operative patients in Ethiopia, almost 12.3%. And then lower in the Mumbai Orthopedic Institute in Dar es Salaam, almost 25%. And higher than study even in prevalence of surgical site open femur fracture in India, 2011. So so patients who took antibiotics 6 hours of from 6 hours of injury are 0.98 times more likely to develop surgical site infection compared to who took antibiotic before 6 hours of injury. This is a similar value. This also similar when studied in China. In open fracture, surgical site profoundly increase when the administration antibiotic, especially prophylactic antibiotics, is delayed for more than 6 hours. In studies, those who operate more than one debridement, again, almost 3.91 times more likely to develop surgical site infections than those who have operated more than one debridement. This almost the probability is done in USA almost similar due to this. It shows maybe this the description is due to maybe operation shows the complexity of the injury if you did more than one debridement. So this limitation, as I said, it rely on electronic medical record and the patient chart record. So it is cross-sectional study and done in single center. As conclusion, so the prevalence is almost 12.62%. Delaying timing to start antibiotic more than 6 hours, more than one debridement, before definitive surgery was very statically associated with this cervical site infection. So recommendations for specific institutions for development institutions have development awareness for hospital healthcare to initiate once patient arrive and then as much as possible early for open fever fracture. Orthopedic surgeons should be aware of this cervical site infection, its complications to prevent suffering of patients by reoperation in hospital stay. Federal Ministry and for health educator and the researchers. So lastly, I want to acknowledge for Bardar University and the orthopedic department to give me chance to do this paper. And my advisor special for Dr. Walker is now head of Department of Orthopedics in Bardar University Orthopedic Department in Mr. Gaba. Lastly, for my collector, data collector. Thank you.
I think we can start the questions. I think
what I see is the number of males is very high, according to the females. It is why is there any explanation for them in the temporary process? Second, to Dr. Mangistu, what do you advise to our country as a study which antibiotics is regarding to give some place where there is no microbiology studies or that clinically, some even in countries we do for experience, what you suggest to this solution? Thank you very much.
so. My question was to Dr. Asha. So as he said, the prevalence of infection is report is around 40%. So did you classify another one classification which was clinically important? After classification as well as infection rate. So did you classify them? And the second question is to Dr. Shoma. So the risk of early complication is higher in those patients who have higher diabetes. So that is a post-operative assessment. So what is the important post-operative assessment? Is that for early follow-up and early intervention, or what's your suggestion to get higher than index? Because as you see from the logistic regression, those patients who have higher data index are significant restricted early complication. So what is the recommendation for those patients is that
presentation. You said that you presented the consecutive series, and I noticed that your numbers of male and female comes were exactly the same. Is that common in pelvic injury that you get exactly the same?
Okay, thank you, Dr. Tim, for your next question. So in our data, so the distribution was equal, like 74 minutes and 74 days. So when you see the elite in image and male, and the previous study there was significant difference. So as in our study, males have higher elite than the group. Males was 20 versus 27. So that variation samples. There is a patient-specific variation among
Okay. Thank you, our presenters, for the wonderful presentations. You may take your seat. Round of applause to our presenters. Thank you. And thank you to our moderators for the wonderful moderation of and round of applause for our moderators. we are now going to go for a very short and very quick tea break, okay? You only have 10 minutes because we want to go home early, right? So 10 minutes, just go grab coffee, grab your snack. You can sign International by Jen, and Terry and Fred from the signing team will give short talks and will be followed by the functional. I would like to invite the moderators for this session